Welcome to Raaonline. Today's topic is laboratory diagnosis of infectious disease during pregnancy. So, the majority of infections are self-limited or readily respond to antibacterial or antiviral therapy in healthy immunocompetent individual. But pregnancy is a physiologically unique period when otherwise healthy women are at risk for serious infection-related complications due to the obligatory immunological changes to allow for a diminished inflammatory response and fetal tolerance. So, during pregnancy, the inflammatory response is diminished because the pregnant woman has to immunologically tolerate the fetus. So, pregnancy is an immunocompromised state. So, these infection-related complications may be more in pregnant women. Maternal risk of infection is dangerous to the mother, and it is also dangerous to the child because it can transmit to the baby. Now, coming to vertical what is vertical transmission? Vertical transmission is parent to child transmission of diseases. So, it can happen in the antenatal period through the placenta. It can happen during labor, intrapartum period, during passage through the birth canal. It can happen in the postpartum period while breastfeeding. Now, vertical transmission happens through the transplacental passage, and if the mother gets infected during the period of organogenesis, it can result in severe congenital malformations and long-term disability, and especially with rubella and cytomegalovirus. So, these viral infections intrauterine cause congenital anomalies. Now, fetal infections ascending maternal infection of vagina and cervix can lead to chorioamnitis and preterm labor. Now, intrapartum infections during labor, they can be hematogenous, direct spread can occur during the birth. It can account for perinatal transmission of HIV through the vaginal secretions to the baby. Herpes zoster can go directly from the vaginal secretions to the baby's eyes and lungs. And Group B streptococci can also spread through vaginal secretions during the process of childbirth. Postnatal transmission is via the breastfeeding. Now, coming to the diagnostic cycle. So, whenever we have a patient, she will be visiting to the gynecologist or an obstetrician, and then we will provide her with a provisional diagnosis. Then we will collect a sample for a suspected infection. Now, they will fill a requisition form and they will properly label the vacutainer with the patient. Now, this vacutainer along with the filled in application form, or if you have a paperless hospital, thus the vacutainer, this will go and then it will go to the lab where they will be issuing the records in the computer or entering into the computer, which you can access in your system. Now, coming to the pre-analytical phases of sample collection. So, what we realize is that specimen collection and transport is affected by so many factors, whether there has been an appropriate collection device, an appropriate container or an appropriate culture media, whether there was a proper labeling of the containers, whether the samples were obtained before starting the antibiotics or after starting the antibiotics, whether there is a sufficient amount of specimen which has been collected for identifying the microorganisms, and was the specimen collected at an optimal day of fever, like in the first few days of illness or in the first few days of fever or after the fever subsided, or during the acute phase or during the latent phase of the disease, and whether the collection was from an actual site with a minimum contamination. So, all these are called as a pre-analytical phases of sample collection. Now, in the actual doing a lab analysis of a specimen obtained, we need to look at the specimen, that is macroscopy. We need to look at the specimen under microscope. We need to culture. We can do molecular analysis. We can do the serology testing for detecting the antibodies present in that blood, and then we can also do the biochemical identification and characterization of those microorganisms. Now, in the post-analytical phase, we have to do the reporting of and we have to identify the antibiotics for which it is sensitive, and then actual treatment begins. Now, infections in pregnancy can be bacterial, viral, fungal or parasitic infections. So, bacterial infections in pregnancies can be Group B streptococci, tuberculosis, bacterial vaginosis, gonorrhea, syphilis, urinary tract infections, and commonly chlamydia. Urinary tract infections include the E. coli and the Klebsiella. Viral infections in pregnancies are commonly HIV in pregnancy, TORCH, which stands for Toxoplasma others, Rubella, cytomegalovirus, and herpes. Herpes simplex virus infections in pregnancies, herpes zoster virus in pregnancies, hepatitis B, human papilloma virus in pregnancy, and varicella zoster virus in pregnancies. Fungal infection include candidiasis in pregnancy, which is the most commonest type. Parasitic infections can be malaria or dengue. Now, group B streptococcal infections, they are caused by Streptococcus agalacti, and the risk factors for group B streptococci or Streptococcus galacti is positive GBM cultures in this pregnancy and PROM longer than 18 hours or an intrapartum maternal fever of more than 38. So, the diagnosis is done usually by screening between 36 to 37 weeks of pregnancy, and we need for GBS we need a rectal swab and a high vaginal swab. So, this is also a question asked in the exam, what swab we use for GBS. So, we use a rectal swab and a high vaginal swab for, and when do we do the screening? We do the screening between 36 and 37 weeks of pregnancy. And this GBS predisposes to intrapartum fevers and PROM and preterm labor. Coming to tuberculosis, the risk factors for tuberculosis include positive family history or past history of tuberculosis, low socioeconomic status, areas with high prevalence of tuberculosis or family history or contact. HIV with tuberculosis is common. Alcohol addiction can be associated with tuberculosis, and intravenous drug abusers also have a preponderance to get tuberculosis.